So good evening, everyone. My name is Dr. G, and I'll be doing the fifth part of this beautification webinar series, which is going to be focusing on the perioral region. Now, this is predominantly going to be the lips. I will touch base on the marionettes and the nasolabial folds. I'm hoping more so in the question and answer section. Obviously, it's going to be too much to try and cover just in a short space of time. So this will probably last around maybe 30 to 40 minutes, and then we'll have a question and answers towards the end, as we always have. I have put the link out for you guys for next week's webinar, as well as the YouTube channel. So, if you want to play things back, then you can do so at your own convenience. So the YouTube link is there in the description, and I'll post this out again towards the end. So I'll just turn the screen around so you can see, and we'll make a start. So as I've said, this will be focusing predominantly on the lips, and no, that isn't a picture of me in case some of you are wondering. I know lockdown is getting to some of us, but no, that's not me at the moment. Maybe next week. Right, so as always, the agenda is pretty much the same. So we're going to talk about the aging process, and this time it's going to be obviously focusing around the perioral region or the lips, and we'll talk about the anatomy. In fact, there's going to be a lot to do with anatomy today when it comes to injecting the lips, and probably less so when it comes to injection technique, purely because there's so many techniques out there, and I'd spend here all day trying to go through every single technique. So the focus is actually going to be on the relevant anatomy, which then would allow you to make an informed choice as to what technique you would like to use. And there's no such thing as one technique being safer than the other. They all carry risk, and so we'll talk about techniques later on. So as a general introduction, the lips, there's a massive demand for lip filler, if you like. And, this is a worldwide thing. Yes, some countries are slightly behind than others, but it's not just the Western world we're talking about here. Even in the Far East, whether it's China, whether it's India, Australasia, it's a huge thing worldwide to have voluptuous lips or symmetrical lips or enhanced lips in one way or another. And a huge reason behind this is social media, whether it's the Kardashians or whether it's Hollywood stars. Social media portrays lips as being a very sexy part to the face. And as from a practitioner's point of view, it's a very challenging area. It's a thing that we do very often. I'm sure some of you see many lip patients on a daily basis, but it doesn't go without saying, it's still a very challenging area because no two lips are the same. And furthermore, we all know how vascular the lips are, which is one of the main reasons why we don't use other substances other than HA. For example, polyallyl lactic acid or calcium hydroxyapatite. So we tend to stick to hyaluronic acid, especially coming into the perioral region. And it's a very dynamic region, which I'll come on to in a little bit more detail. So the lips obviously play a huge part in a selfie. And as you can see here, we've got Kim Kardashian flaunting her assets here in the top right. And that's actually a book. She actually has a book on how to take a selfie. And this is the actual Wikipedia definition for what a selfie is. And I believe it's also now in the dictionary. So, a huge part of a selfie is focused on the lips. Obviously looking glamorous and having your makeup done and your hair, etc. But the lips play a huge role. Some of you are following me on social media or on Instagram, and you see that I'll be taking a picture of myself with my lips, I'm pouting, and that's just a part of this whole selfie process, so to speak. So lips play a huge role, as I said earlier on, because of social media. And, what's this slide trying to summarize is, in general, bigger seems to be better. There's a lot of people that are wanting bigger lips, and we'll talk about the size later on and what the proportion should actually be. But the larger the lip, this is associated with beauty in various parts of the world. Now, this lady is obviously from an Afro-Caribbean tribe, and they expand their lips. And this is going to be a sign of fertility and beauty and youthfulness. you know, so this is how they measure amongst each other. So obviously this is not really a trend in the Western world, and it's not something I can do. It's out of my skill set, this, but you know, there's various trends out there around the world. And as I said, it's a very focal point of the face, and you know, your lips, in my eyes, are either going to be sexy or they're not. You know, there's no real in between. And you know, they vary amongst culture, ethnicity, genders as well. And just like I've said, it's different all around the world. And it's a sign of attention and emotion. And as the Greeks would put it, it's actually an erogenous zone. And I've got a couple of funny slides, or funny-ish slides, I hope you see the humor later on, regarding actual medical studies done regarding the lips being an erogenous zone or a sexualized area. And that's mainly because of all the nerve endings that are associated with the lips. And red is, as we typically would, associate it with love. And this was a study that was actually done by Ian Stephen back in 2010. And he said here that red lips have been considered attractive in women, possibly because they mimic vasodilation associated with sexual arousal. So when it comes to the sexual arousal state, and I'm not a sex expert here, I'm not trying to give you a medical study on this, but at the end of the day, you know, there's going to be engorgement of blood vessels, and this causes an enlarging. And this is a psychological study that he did, and he's obviously linked red lips to be associated with you know, sexual arousal because of vasodilation. And if you have a look at these pictures here, you know, this is the original picture of the lady in the study, and they've changed the lightness here, they've changed the redness, and they've changed the yellowness. And you can automatically see that the redder the lip, the more attractive. And then we have a lot of patients that have no lips. And so what do they try and do themselves to mimic having lips? Simple, lipstick. You know, if you were to ask 100 women before they go out on a night out, what will they have in their handbag? Lipstick will definitely be one of the items. You know, so that's what we're constantly trying to, or patients are constantly trying to do, maintain voluptuous, voluminous lips, because it's a sign of youthfulness as well as beauty. So face is in the eye of the beholder, and this is a study done by Joseph Arizpe a few years ago, I think back in 2014. References are at the bottom of the slides, and what you'll be able to see from here is basically they were looking at the eye scanning patterns. So as soon as you look in the face, now here in the top, okay, so here this was done in the 1960s. So it was in 1967, Yarbus and colleagues first determined that when we look at the face, we focus immediately on the eyes, as you can see here, and then the eyes scan down to the nose and the mouth, and then it scans the rest of the face. And this was a more recent study done back in 2012, I believe, and it's a very similar concept here that they've concluded, which is that we focus on the eyes and then down into the mouth. So this is more of a T shape, you know. So one of the first things that we're trying to augment or enhance in terms of beautification of the face in general, guess what? It's going to be the eyes, and it's going to be the mouth or the lips. So periorbital and the perioral regions. Just a couple of interesting slides here. So this is cheiloscopy, and I'm not sure if some of you know what that is, but essentially it's forensic odontology. And just like forensics, everybody's fingerprint on this planet is different. You know, everybody has a unique genetic fingerprint. And in the same way, the lips are also unique. Everybody has a unique set of lips, and hence, you know, they can be used in forensics as well. And this is a classification called Suzuki classification, and there's basically 6 different types of lips. And if you look at these pictures, some of you are probably not familiar with this study, or that lips can be used in forensics, but I'm sure some of you will have actually seen these kind of real patients where they have certain lip lines that look like this. This was the paper which, you know, hopefully, you know, we'll see the humor in this, but it's actually published in the Journal of Sexual Medicine. And the title, as you can read here, is Vaginal Orgasm is More Prevalent Among Women with a Prominent Tubercle of the Upper Lip. Now, this was only one study done, so we can't generalize and say this is the be all and end all, but it does go to show that in keeping with what I was saying earlier on, that the lips are a very erogenous zone, and therefore treating that area properly to get an ideal aesthetic outcome is paramount. And then a lot of it obviously boils down to the practitioner. If you're interested in that paper, just hit me up with a message afterwards and I can send you the link. So what happens during the aging process of the lips? So we get loss of volume in the vermilion border. There's flattening of the cupid's bow, a bit of asymmetry going on. There's lengthening of the top lip, so the upper cutaneous lip, which is from the base of the nose to the vermilion border. And this actually gets longer. It's elongated as we age. Fine lines, or we call them smoker's lines or kisser's lines, if you like. And there's also bony resorption. Now, this could be at the mandible level, at the maxillary level, or it could even just simply be loss of teeth, because that's going to affect certain dynamic movements, for example, how you laugh. And a lot of us think that as we age, the lips shrink with size, in terms of size, but they don't. Okay, so as you can see on this side, previously, as I've said, there's a whole list here actually of what happens to the lips as we age, but we do not lose volume. Okay, so I'm sure some of you here are thinking as we get older, we lose the volume in the lips. We don't. Okay, very popular paper by Penner and colleagues back in 2009. I think they've done a few studies actually, which and they've shown us that histologically there is no change in volume of the lips. However, there is change within the muscle. So if you look at this picture here, I'm sure you can see my cursor. Okay, so what you'll see here basically in number 3 is the muscle. So this part over here is the cutis. Okay, underneath, what will you have under the skin? This is your subcutaneous layer in a slightly lighter color. And then this pinky color here is your Orbicularis Oris muscle. And what happens as we age is initially it's a J shape like this. So it starts up here, and as the lip comes down, it rolls out like this. This is the bottom of the J. But as we age, this little leg of the J, guess what happens? It comes backwards and it straightens out. So this J shape of the muscle becomes an I shape. And so the muscle is basically atrophying. It's getting smaller as we age. But the volume of the lip doesn't necessarily change. So, how can we perceive a woman's age? There was another interesting study done by David Gunn et al., again around the 2009 era. And they did quite a huge study, actually, and they were trying to pinpoint, how can we tell a woman's age? What do we look at in terms of determining her age? And these are very important, especially for you guys out there, because we all know you should never ask a woman her age, should we? It's called being polite. So the first thing was skin wrinkling. If there's slight fine lines or wrinkles, you will be able to tell that she's aging. The graying of the hair also will give you a rough idea. And the third thing, very importantly, is the lip height. Okay, so we're talking about from the base of the nose to the lip, which is a cutaneous lip. And as I said to you earlier on, this elongates, so it gets longer as we age. And so that's going to be giving away roughly what decade of age they're going to be in. So just looking at this is just your gross anatomy of the lip. I'm sure a lot of you are very familiar with these terms. You've got your vermilion border, oral commissures, and your cupid's bow. You've got 2 very thin columns up here, which is your philtrum columns, and obviously the peak of the cupid's bow is your GK point. And this is very important, the tubercles, because the way I see tubercles is like cushions. So there's 5 cushions in total. You've got 2 large cushions in the bottom lip, and then you got 3 in the top lip. And what we're trying to do is re-inflate these cushions, therefore add that volume back in the lips, and then be able to contour by focusing on the vermilion border. So taking the anatomy into quite a bit of detail now, the next few slides. So let's look at the histology first. And the layers of the lip are very straightforward. Okay, so you've got the skin. Beneath the skin, so you're going to have the subcutaneous fat, and beneath the fat you'll have the Orbicularis Oris muscle, and beneath this you're going to be having the oral mucosa. And this cross-section shows it quite beautifully. So here is your skin up here. And underneath here, this is all your fat. These long tubes here are your hair follicles, okay? Now, they're obviously going to be a lot more prevalent in the male face. And then beneath the fat here is your Orbicularis Oris muscle. And beneath this, yeah, you'll have some glands, but you'll also be in this oral mucosa, which is your submucosal plane. And now we'll take a look at the vascular considerations. And this is very important when it comes to lip injections in general, because it's a very high risk area. The anatomy is never the same in any two patients. There's always going to be at least a very small degree of variation. And what you see in a textbook is just an average depiction of what is actually under the face of that patient. So the anatomy will vary a lot. Now, you know, I get asked a lot of questions, for example, the 4mm technique or the Russian technique for the lips, cannula, needle, boluses, and so forth. And they're all irrelevant. I can do them all. I'll get a nice result with them all. But the most important thing is just knowing, you know, the anatomy, where the vessels are, and which plane you need to be injecting in. So we will cover this. And we know about the facial artery. Okay, it's a huge artery. It's anterior, it's a branch of the external carotid artery, runs submandibular, and then anterior to the anterior border of the masseter, approximately by 1 centimeter in front. It emerges into the face, runs up to the modiolus, which is at the level of the oral commissure, and then it runs up superficially towards the alar base. Some studies will say as soon as it passes the modiolus, it becomes an angular artery. Some say as soon as it branches off and gives the lateral nasal artery, from then on it becomes an angular artery. But that's your general route of the facial artery. And one of the branches, especially for the top lip, is the superior labii artery. And the lateral third, so as soon as it branches off the facial artery, the lateral third over here is above the muscle. And then it goes beneath the muscle and it weaves in and out in the medial 2/3 of it. So that's very important to know. And then we need to consider the position, because it does vary. Is the artery submuscular? Is it subcutaneous? Is it, is it submucosal? Is it subcutaneous, or is it intramuscular? And then what depth is it? You know, are the arteries 2 millimeters deep, 3 millimeters, 4, 6, 9? And just being aware of these is going to implement your practice and make you a safer practitioner. But at the end of the day, unless you have a fancy scanner, you can never guarantee anything. And the way I see it is, it's like driving a car. You could be the best driver in the world from the age of 18, but the chances are from the age of 18 up until the age of 80, you might be a very good driver, but the chances are you might have an accident. Why? Because you don't know what other drivers are like. And the same principle when it comes to injecting the lips. So you could be the best injector in the world, but we don't know what the patient is like. Okay, so the way I put it, if you're going to be injecting for 5, 10, 20, 30 years, the chances are you're going to be having some sort of complication. And the chances are it might very well be a vascular occlusion. Just looking at these diagrams over here, done by Lee Young and his colleagues in 2014. So what you'll see here where this triangle is the superior labii artery, and then it's giving off its columella artery here with these two small arrows. Okay, this is another version. This is your superior labii artery here with the big triangle, and it's giving off its columella artery just up here. So another study done by Lee and colleagues only a couple of years ago, actually. And as you see in the diagram here on the left-hand side, you can see the facial artery. It's about just between 1 centimeter and 1.5 centimeters away from the oral commissure. It gives up a branch of the superior labii artery. And, you know, in most cases, it's above the level of the oral commissure. So the branch is above the level of the oral commissure. And if you look at this image on the right-hand side, what we're looking at here is inferior labii artery, which is just here. And in 80% of cases, it branches off from the level of the oral commissure. We'll go into this in a little bit more detail with some better diagrams. So let's take a look at the superior labii artery. Okay, so there's basically 4 types. Now, if you look, here's your cadaveric dissections here. But if you look at these diagrams, the superior labii artery, or let's look at a simplified version. We can look at either diagram. Superior labii artery, where's it coming from? Directly from the facial artery. If you look at the type 2, the superior labii artery, what is it giving? It's giving the alar branch over here. In type 3, the superior labii artery has no other branches. So it's the only artery coming off the facial artery for the top lip. And then in type 4, there is no superior labii artery. So some of your patients you're injecting may not even have a superior labii artery. And the lips are supplied predominantly by the inferior labii artery. And this was a study done by Lee et al. In 2015, where they used 60 hemifaces. And these were very consistent findings that they've had. And the most important thing is, and this applies to any principle of facial aesthetics, is when we're doing injections, it's all about the depth. It's all about the depth of the tip of your needle. And they've concluded here that the superior labii artery was 3 millimeters deep. So just have a little think for a second how little 3 millimeters is. And then we can think about the technique later on. The inferior labii artery is not very much talked about, should I say, in comparison to the superior labii artery. A lot of practitioners know about the SLA, and it's, above the muscle for the lateral third, then it oscillates in and out, and it's roughly 3 to 4 millimeters deep. But there's not much talk, from my experience anyway, about the inferior labii artery. And here's another classification from the same author, Lee and colleagues, back in 2015, and you can see the distribution of supply to the bottom lip. Now, the HLA is your horizontal labii artery, so branch of the facial artery. But let's just look at the bottom 3 here. So here, the inferior labii artery, where is it? It's not there, it's absent. And in part 2 over here, you have your inferior labii artery coming from the facial artery. And as I said earlier on, in 80% of the cases, it's at the level of the oral commissure. And then in the type C, you have the inferior labii artery, but guess where it comes from? It comes from the superior labii artery. Okay, so much variation, and they are quite prevalent. And in the same study, they had 63 faces, or hemifaces, and it's quite surprising actually. The type A was most prevalent. So in just over half of their cases, 52% of their cases, from 63 faces, there was no inferior labii artery. Okay, so just some very interesting facts there. Now, what are the sources of the inferior labii artery? A very good paper here by Tansatit and colleagues, just published last year in the Journal of Plastic and Reconstructive Surgery. And here they show, and I'll show you some slides afterwards with actual imaging, the 5 sources of the inferior labii artery. So the first source is the labiomental, which you see here. So you've got your facial artery, then you have your labiomental artery. Okay, that's your first source of giving your inferior labii artery. And then you have your modiola, which is at the level of the oral commissure. You have your ascending mental artery, your facial artery, as we already know, and then I've just told you in the previous slide, sometimes you get it from the superior labii artery. So your inferior labii artery can come from any one of these 5 places. So don't always think that you see in a textbook, very classically, here's your facial artery, superficial labii, and inferior labii, job done. Okay, so there are a lot of variation amongst patients. And it's the same, from the same study, these are the actual slides where you'll be able to see, so this very thick artery over here is your facial artery, superior labii artery over here, and you'll see it's very similar down here too, huge facial artery, superior labii artery here, and then you'll be giving branches of your inferior labii artery, or it could be the horizontal labii artery. Okay, so you can have a look at this in a little bit more detail when you pause it on YouTube, but just very useful to know. And again, from the same study, they did a ultrasound scan to see where the inferior lay-by artery was. And look what they found here. So you've got the skin, subcutaneous fat, and then you had your inferior lay-by artery, which tells you it's actually very superficial. So injection plane is very, very important. And this is what this slide is going to summarize for you guys. So this was done by a very famous clinical anatomist, Sebastian Cotofana, and I love to watch his lectures actually when I'm sometimes presenting myself in IMCAS or Monaco, and it's very interesting, very, very amazing guy. And he basically conducted a multi-centered study from 3 countries, 6 centers from 3 countries, and they had 386 hemiphases. So these figures are fairly on point when we talk about their findings. So they found that the arteries were in the subcutaneous layer. So remember, there's the skin and then subcutaneous. So it was in the arteries were found in the subcutaneous layer in only 1.7% of the 386 spaces. It was found in the next layer, which is your muscular layer, intramuscular, okay, so the Orbicularis Oris. It was found within that layer in 17.5% of patients. But guess where they found it the most? They found the arteries in the submucosal plane. So remember, skin, subcutaneous, muscle, submucosal. And it was 78.1%. So we're talking around 80% of cases, your vessels are going to be in the submucosal plane. And as for depth, depending on which study you're going to read, again, I'm just generalizing it, as giving an average, we're talking between 3 and 5 millimeters deep, okay? So it's very important when it comes to picking your injection technique. Now, the Orbicularis Oris, not forgetting this muscle, it's a very dynamic muscle, and just very briefly going through its anatomy, there's 2 layers to this muscle. You have a superficial compartment, which is the muscle of facial expression, and then you have the deep, which is the buccinator muscle. And the facial artery is often found between these 2, and it's usually fixed in the modiolus. And as I said to you earlier on, the modiolus is normally between 1 and 1.5 centimeters from the oral commissure. So what do you do when it comes to clinical assessment of the patient? So you want to assess them static, you want to assess them in a dynamic state, so smiling, pursing their lips, blowing their cheeks, assess them from the profiles to see, you know, ideally the top lip is protruding ever so slightly, assessing for symmetry, shape, color, texture, etc. And not forgetting the dental history, okay? Because if they've got 2 or 3 loss of teeth on one side, there's going to be sub-element of submalar hollowing over here. And, you know, so don't automatically think, or the patient may think, that by adding more volume in the lips is going to improve that problem, okay? So dentition is very important too. So what I'll be focusing on when it comes to injecting the lips, so this is the middle, so we're going to be focusing on the middle fifths, but this is called the vertical fifths assessment, done by Fitzgerald back in 2016, and essentially you're going to split the face into fifths. So we're talking from the lateral aspect of the face to the lateral canthus to the medial canthus, the intercanthal distance, and so forth. So when it comes to the lips, what we're looking at is, if you look at my face just over here, sorry, you've got your intercanthal distance from your medial canthus from one eye to the other eye. Now, as we age, this does not change. So by the time the female face hits the age of, let's say, around 20, 21, the intercanthal distance will remain the same for the rest of her life. Therefore, it's a very good indicator when assessing the face. Now, if you visualize 2 lines coming down from the intercanthal distance, it should also be the width of the ala. So the width of the nose should fit within those 2 lines, and it should also intersect the lips. And it shows that the most of the lip volume should be between those 2 lines. Any work outside of those 2 lines on the lips is going to give her what kind of look? A sausage-shaped look. It's not going to be aesthetically pleasing. And if you continue the lines down, then the chin should also be in the ideal width. Now, when you're looking at the male face and doing the male chin, as I said, then you're looking at the oral commissures. But for the female, we're looking at the intercanthal distance, interalar distance, the bulk of the lips, will fit within those two lines. And this is looking at it from a profile view. You can see the distance is only a third from the base of the nose to the top lip, and then from the bottom lip to the chin it's 2/3. So making sure these proportions are correct. Some of you have probably heard of the golden ratio, and this is very useful, especially in the Western world. However, in general, it doesn't fit everybody. Okay, it's not one rule fits all. Some patients will say, I want my top lip to be slightly bigger. And just because we're looking at aesthetics from a very objective viewpoint doesn't mean you cannot do that. Okay, and personally what I find is that if the skin is colored, you know, Asian, black, etc., then a 1-to-1 ratio tends to work better. Whereas in Caucasians, I do personally find that this golden ratio actually works amazing. And this is 1 to 1.6 if some of you didn't know. Now, this is a very important part, and it is often neglected, not because of the practitioner per se, but usually because of budget. You know, if we're trying to get them to do the nose and the chin and the lips, the budget obviously increases, you know, 3, 4, 5-fold. But it's very important to try and assess you know, the face from the side. And if you look at this diagram over here, you can see there's 4 different S shapes, if you like. We've heard of the OG curve, but Hong et al. Actually published a paper this year itself. So this is a very, very new paper, and they're looking at 4 S's of the face and profile. So if you look here, you've got the frontal nasal S, okay, then the nasal palatine, and then here you got from the lower lip and the chin, submandibular, and then here's your OG curve. Okay, so looking at these curves is very important, and I did show you, I believe, in my webinar a couple of weeks ago about the Steiner's lines and Ricketts lines, you know, joining lines from the nose or the base of the nose or the tip of the nose right down to the lips, down to the chin, and trying to see what is out of proportion and what isn't. Okay, so looking at the profile view is very important. What kind of numbing cream can we use or injections for anesthesia? Well, quite frankly, some patients don't want anything. You might be surprised at that, but I do have some patients that say, look, it doesn't make a difference, just crack on. They've got a very high pain threshold, absolutely fine. But for most, what you'll find is your topical anesthesia is more than enough. Now, this may be your EMLA cream, your LMX, whatever it is from whatever part of the world you're from, but topical tends to work well. And if you want to take the step further, you could always do a block. Okay, so this could be an infraorbital nerve block, which can be done intraorally or extraorally, and same with the mental block, intraorally or extraorally. The downside of doing a block is, let's say they went on to have a vascular occlusion, then the pain element may be slightly masked. Okay, so there's that part to look at it as well. But obviously, pain isn't the only sign when you're having a vascular occlusion. We're talking about skin changes, capillary refill, but it's nice to know if the pain is blowing out of proportion or not. But you will reduce that element if you're using an injection block. So just keep that in mind. And also try and assess the face before giving them a block, because there will be some mild paralysis of some muscles. And usually I find lidocaine 1% is absolutely more than enough. So what injection techniques are we talking about? So these lips I've done here with the Luminera hydraulics lips, which you do get 1.25 mil in a syringe. So those that are wanting your volume, brilliant. Those that want small amounts in the lips, it's still brilliant because you can focus the product elsewhere, perioral lines, etc. But these are your very common techniques. So you'll have heard of tenting, which is predominantly what your Russian technique is based on, tenting and layering. Then you have your bog standard linear threads. You've got your bolus technique. Remember, I spoke about the 5 main tubercles, and we're trying to expand these tubercles. Whether you use a 27 gauge or a 30 gauge, again, is very debatable. And the way I see this is a lot of products are FDA approved. And to get FDA approval, you know, they're testing the safety as well of the products and everything that comes with it. And a lot of these products are coming with a 27 gauge. Yes, some come with 29 or 30, but 27 gauge seems to be your gold standard till date. And, you know, it is safe to use. It's what I use. And, you know, if it wasn't safe, it wouldn't be FDA approved, quite simply put. So don't get bogged down, oh, I need to use a smaller needle. Yeah, you can use a smaller needle, but you'll penetrate the vessel a lot easier too. So there's always a 2 and 4 against many of these arguments. And another one here is a 4mm technique and the 13mm. And does it matter too much? No. You know, and, you know, whoever says that the 4mm technique is the safest technique of them all, you know, maybe needs to have a little bit of a rethink about whatever they're saying, because there is no safe technique. The safe technique is knowing your anatomy. And if we know that, you know, the arteries are, let's say, 4mm deep or 3mm deep, and you stay very superficial in the subcutaneous plane with a 13mm needle, you're not going to have any problems. Okay, so it's the knowing the anatomy that makes you safe, not necessarily saying, oh, the arteries are 3 or 4mm deep. Hey, everyone, I'm going to go buy some 4mm needles and I'm going to use a 4mm lip injection technique, you know? So don't get bogged down into, you know, the actual tool per se. A good practitioner will pick a tool, but the best practitioner will be able to use any tool. Okay, so don't fall for the hype about certain techniques, whether it's Russian technique, whether it's the 4mm lip technique. And cannula versus needle. Now this has been around for a very long time, this debate. And I'm a needle guy. You know, whatever I'm going to do in the face, for the most part, I tend to use a needle. Can I use a cannula? Yes, not a problem. But I like the precision of a needle, simply put. You know, I get asked all the time, needle, cannula, simple, needle. When I'm doing non-surgical rhinoplasty, needle. And that's because wherever I'm injecting the product, I know exactly where it is. The precision cannot be matched. As for a cannula, yes, from a safety perspective, you're going to be safer, not safe, safer, okay? And there's also a risk of having an occlusion with a cannula, as there is with a needle. And the other way that I look at it is, if you have an occlusion with a needle, it's going to be bad. But you have an occlusion with a cannula, it's going to be 10 times worse, because you've literally just cannulated the artery. So although cannula might be safer, if you end up having a complication, it's going to be worse. Okay, so always keep these things in mind. And if you look at the technique that I tend to use, these are lips that I've done. If you look at the diagram on the right over here, what you'll see is I've worked around the vermilion border. This doesn't denote the number of injections, by the way. This just shows the direction of the needle. And if you look very carefully, the lateral part of the lip over here, I've not done anything. She's got a nice upturned corner of the mouth, the oral commissure. So did I need to add volume in this part of the lip? No, because she'll end up having a sausage lip. So you inject the vermilion border, obviously for definition, and then you want to be injecting the body. And whether you do a little bolus injection here and here, or you could go in with a linear thread, is entirely up to you. And same with the top lip. So, you know, these cases are all being done with a needle. And just be careful when it comes to the Cupid's bow. Sometimes if you put too much in, you'll flatten the Cupid's bow, you'll masculinize the face, and she won't be very thankful for it. And in terms of how you inject the Cupid's bow, multiple ways to do it. You can actually go in, if you look at the screen here, this diagram shows coming in from the GK point medially, and again this way. Or you could actually start at the bottom of the Cupid's bow and you can inject upwards and do a linear thread as well. So there's various ways that you can inject. And in some patients, I don't even inject the V. I will just do my linear thread here laterally. And because I get such a nice lift at the GK point, I tend not to then do the Cupid's bow. Okay. And as for the philtrum columns, this is hit and miss. Do I do the philtrum columns in everybody? No. If it's something the patient themselves asks for, then I will consider doing it. But I don't necessarily say, oh, why don't we do your philtrum columns too? And the main reason is risk. You know, it is a very risky area. You'll have your philtral arteries, your carmella artery, you know, which is supplying the tip of the nose. So it is an area that you want to be very careful with. Sometimes what you'll find is once you do lips here in the perioral region and the lateral aspect of the top lip, just where my cursor is, there's a bit of an indentation just over here. a little line, especially on emotion. So it's a dynamic area. And the reason this, well, what I believe is the reason is because there's loss of hair follicles. And the male face has a lot of hair follicles. If you look at my face here, I've obviously got a mustache, I've got a lot of hair follicles. Therefore, if I were to shave off my mustache, I would not have that crease after the lip filler. However, in a female face, you don't really have many hair follicles. Therefore, the stability of the dermis isn't as strong. And what are we doing to the vermilion border, or close enough to the dermis? We're expanding it. Okay, so sometimes it might get a bit of a crease, which you can fill directly if you wish. And also, another point that I like to make is sometimes there's the lengthening of the cutaneous lip. So this is from the base of the nose or the alar spine right down to the lip. So that's your cutaneous lip, basically where my mustache is. And if this is lengthening, what would you want to do? Would you want to shorten it? How can you shorten it? So what I tend to do is I have an entry point, maybe around 0.5 centimeter from the oral commissure. I'll use a 25 gauge cannula, and I will feed this up into this region of the superior cutaneous lip, and I will put a very small light product. And I find this will allow for a nice eversion of the top lip without even filling the lip. So that's just a little technique. And again, there's lots of tips and tricks that I could be giving. I'd be here all day, to be fair with you, but we'll leave some stuff for the questions and answers. So complications, let's look at complications. I'm sure some of you have had these. I've probably had most, if not all of these as well. And, you know, it's not about, you know, I always say this, you know, you get a good practitioner and you get the best practitioner. It's not about, you know, the good practitioner, so to speak, is going to be like, oh, I've never had a complication. But the best practitioner is going to be like, no, actually, I've had X, Y, and Z, but this is how I've managed it. So, you know, knowing how to manage it is very important. And bleeding, bruising, hematoma is very common. Bruising can be tricky. Why is that? Because it can mask a vascular occlusion. So typically when a vascular occlusion is coming on, guess what it's going to look like? Either a bruise or a hematoma. So, you know, having that eye for detail and that skill set to know the difference between a bruise, hematoma, and a vascular occlusion is important. Lumps and nodules, you know, they could be inflammatory, non-inflammatory, asymmetry in the lips, your infections that you can get, whether it's viral or bacterial, and your vascular, which is your common vascular occlusion. And I'm not going to be going into how to manage these because there is the complications webinar in 2 weeks' time. So next week, I'll be talking about the non-surgical rhinoplasty, same time next week. And the week after is the final series, part of the series, which is all to do with complication management. So that does bring me to the end of the perioral, the lips webinar. Hopefully that was very useful. And I know I've definitely included some images and some papers and stuff that you probably wouldn't have seen or come across before. So again, this is all going to be on YouTube if you want to play it back. And I will, in the chat box here in Zoom, I will leave the link for the YouTube channel as well as the link for next week's webinar. And just a word of advice here, next week's webinar, I'm going to limit the amount of people that join. Same with the complications the following week. So when I post the link out today, you know, make sure you grab your seat and we'll take it from there. So there's loads of you on today. So let's have a look at some questions. So yeah, guys, please fire away with questions. Hi, Maurice. You've become my online friend. So you're asking, great presentation, thank you very much. How do you treat the male lip? Well, the male lip is done in a very similar fashion, but it's all about product distribution. So with the male lip, they tend to be a little bit more elongated laterally rather than the focal point being medial, as you would find in a female set of lips. So I tend to inject the full the length of the lip from the oral commissure, because a line from the oral commissure going down to the chin is aesthetically ideal for the male face. But again, injection techniques, you know, I'm not going to bog down into what techniques are, because I can do them all and they all work. It's all about product placement in the male face. Right, guys, let's try and answer these questions because they're firing through just now. Hi, Nenad. Can you elaborate how do you evert the upper lip without injecting the lip? Well, think of it this way. As we age, we've got an elongation of or vertically of the upper cutaneous lip. Now that's because there's atrophy of the Orbicularis Oris muscle. So if above this muscle in the subdermal plane, we are adding volume, you're going to naturally be creating a lift. Okay, so you want a very soft product, and with the cannula subdermally, you're going to be adding volume, because essentially by adding volume up, you're creating an anchor point, and this is likely to roll the lip up. Hi, Darko. How do you treat the perioral lines, perioral wrinkles with filler? Very simple. Where do all these lines start? So perioral lines, both superiorly and inferiorly, they all begin at the vermilion border and then they work outwards. So if you want to initiate treatment on perioral lines, a good thing to do is work on the vermilion border. This is going to stretch the base of the lines, and then you've got either a filler or Botox, whatever you want to use, to actually get rid of the lines. But fillers, like I said, I tend to use the vermilion border first, and then I tend to use toxin afterwards. I'm not a huge fan of actually injecting each individual barcode line. I'm just going to get this screen off. Hi, Maurice. Sorry, okay, so you meant the M lips. Are you on about the Cupid's bow? If that's what you're asking, then just ask again. Hi, Joanna, asking, do I have a favorite technique at the end? Yeah, my technique basically consists of doing both linear threads and bolus technique. So, you know, as you've probably gathered from all these webinars that I'm doing, a lot of it is to do with the anatomy. You know, I'm a huge fan of anatomy, and that's what dictates my treatment injections. And, you know, so for me, if I know that the tubercles are reducing in size as we age, we want to make them bigger. And we've also seen from many studies and papers that having enlarged tubercles is a sign of youthfulness and beauty. So that's where the bolus comes in. And then obviously your linear thread, just to make sure you're getting that nice definition. Hi, Kathy. I think you've become my best friend online too. Why is a VO so traumatic when some of the arteries are severed during surgery without causing necrosis and trauma? Example, columella artery during surgical rhinoplasty. First of all, there's a lot of collateral supply in the lip. When we do facial surgery, you can actually even tie off the facial artery, but the patient doesn't go blind. You're not going to have areas of necrosis. And why is that? Because of collateral supply to the face. And the same principle applies in the lips. You know, if they've had a severed artery, superior or inferior labia artery, there's going to be a collateral supply one way or another. So I think that's very important to keep in mind. And secondly, to answer your question, I agree. When doing a surgical rhinoplasty, the columella artery is routinely cut. Whether that's still best practice now, I'm not sure, but it is routinely cut. And you don't end up with a necrotic nose. Why? Because you've got collateral supply, whether it's the lateral nasal artery or the dorsal nasal artery, there's always going to be a collateral supply. So hopefully that answers your question. Hi, Tatiana. Hope you're okay. When you want to volumize the lips, do you place the product 3 millimeters deep to avoid complications? Yeah, we're talking around 2 to 3 millimeters deep. Yeah. I try and keep it in the subcutaneous plane, because if you're going to inject deeper, either into the muscle or submucosal, then you're running into some dangerous territory there, I think. So you want to be careful, especially injecting deep. That's why I'm not a fan of injecting very thick products by certain companies. So you want a nice, soft, natural, malleable product. Hi, Kathy. My view on the tenting technique. So the tenting technique, I'm not a huge fan of it. Do I do it? Yes. Do I do it often? No. There's a right time and place for everything. You know, all the techniques, even the ones that I don't like, there is a right time and place for it. Now, the tenting, think of it this way. If you're going to be injecting multiple times like this, you're going to increase the risk of having that nasty complication. So, you know, I think it's very traumatic for the patient to have multiple injections. The fact that you're going in more than, you know, quite a fair few times means there's going to naturally be an increased risk. And with a lot of inflammation going on, a lot of vasodilation potentially going on, you're increasing the risk of having that complication every single time. Right, so a lot more, those questions were sent to me privately, so I'm just looking at the general chat over here. Thanks, Karen, Nancy, Militia, Claire, Carla, Jeremy, Joanna, Nenad, Mila. So another very good question here actually is from Emma, who's basically asking, do I inject the vermilion border or the bottom lip? I would probably say in about 50% of patients. So in half of the patients that I see, I tend not to do the vermilion border or the bottom lip on the basis that it will depend if there's ideal demarcation between the mucosa of the lip and the epidermis of the skin. Okay, so if there's a nice demarcation, it's nice and pink, you can tell when the skin becomes lip or vice versa, then is there any real need to inject the vermilion border? Probably not. Obviously, if the demarcation isn't very good, inject the vermilion border. If they have very poor definition, inject the vermilion border. If they've got fine lines periorally, again, inject the vermilion border. But it's not something I would rush to go do. Hi, Vasiliki. Thank you. Yeah, and I'll put the link here in the chat, guys. So if you have a look at the chat there, that's the link for the YouTube channel. Please like and subscribe to the channel. It is growing day by day with all your support. And, you know, these webinars are going to come to an end after 2 more sessions. And if you're wanting me to do more content, hopefully once lockdown is over, I can actually get to the clinic and do some live recordings for you guys. And if you want the education to continue, you know, watch me do lips, watch me do non-surgical rhinoplasty, all for free, then please like and comment and subscribe to the channel. You know, show that support, because that is what is motivating me to do it. There's no other reason to motivate me to do all of this other than you guys that are all watching. So please do show that support. Hi, Nadia. Can I talk a little bit about the lip flip using Botox injections? Yep. So you want to inject 4 injections, 1 unit each of your international Botox, literally into the vermilion border, which is what they say by textbook, if you like. I normally inject 2 millimeters above the vermilion border. So I'm actually injecting into the Orbicularis Oris muscle, and I get a very nice lip flip. And I find the results tend to last 4 to 6 weeks because it's a very dynamic area. So it's not something that I sell as a standalone treatment, but I might have it as an add-on treatment. Thank you, guys. Lots of thank yous. Somebody's asking if I have lip filler in my lips. Do they look full? No, I don't have any lip filler. I'm too scared of needles. So maybe one day. Who would like to inject my lips? Right, guys, I'm just gonna stop the YouTube recording, and this will go live on YouTube tomorrow. So hopefully that was all good and you enjoyed it.